Good morning, everybody. Welcome to another edition of AFR's EMS Case Studies. My name is Chris Ortiz. I'm the EMS Chief for Albuquerque Fire Rescue, and today I'm joined by our Medical Director, Dr. Kim Pruitt.
Hi, Chief.
And we're also joined today by Driver Pat Armijo.
Yes, sir.
Welcome. Thanks for coming to talk with us today. And we have a really interesting case that you wanted to share with us, and it was centered around a pediatric status epilepticus seizure.
Mm-hmm.
Yeah. And this was you're assigned to Rescue 16. You and Engine 16, as well as AAS, were dispatched to a 12 Delta, and you guys arrived on scene first, and the dispatcher notes had advised that it was a 4-year-old who was having seizures.
Yeah.
Now, those are always, as we know, the most difficult and stressful calls as pediatrics in general. Talk with us about what you're thinking and when you're en route to that call.
So initially I was already a little nervous because I was upgraded on a trade at 16s, which I know going into that trade, I was like, there's a high possibility of us having to do some real medicine today. So this call came out, and the driver is Jeff Clark, and on the way there we're kind of, just talking, and like, sometimes these calls come in and it's just, the kid has a history of seizures and the kid's still seizing, so the parents can handle it. Sometimes they call their, medical hotline. They're like, oh, just call 911, and we get there, and it's, they're like, oh, we just wanted to check him out. And so there's, very two sides of this that it can go, and it definitely went the more harsh route, I guess you could say. So we're kind of just talking about different treatments on the way there, just kind of, just spitballing what's going to go on.
Yeah.
So we got there, and initially walked in, and the child was unresponsive on the floor. Had tons of like emesis up and around his mouth, on the floor. You could hear gurgling from the door. So initially the Engine 16 crew did a really good job of BLSing it, and they, kind of leaned the child over, got the vomit out of the airway. They initially started putting him on blow-by oxygen, all while I was trying to gather information. And what was the syndrome called again? He has hypoplastic left heart.
Yeah, so he had a hypoplastic left heart, which is a heart condition where the heart doesn't beat really strong.
And so whenever the mom told me that, I honestly had no idea what that even was. So I just kind of typed it on MDT and was like, we'll file this, wait for later, because we're not going to fix this right now. So that was kind of the basis of when we first got to scene and what happened up to that point.
That's great. Great job by Engine 16 on the BLS measures to address that airway early, so it kind of cleans up the scene for you a little bit, so to speak, so you can focus on some of the other things that are going on. So great job by them. We documented some initial vitals. It looks like the heart rate was around 152. We were able to get a pressure, which isn't always easy on the 4-year-olds, 126/50, setting 86%. The engine was already doing some blow-by, I think you had mentioned. Sugar was good, which is key. We always want to check sugar in those kiddos, especially when they're having a seizure. We mentioned the hypoplastic left heart syndrome, and you don't have to feel bad because I had never heard about that until we discussed it today. So, Doc, help us out and kind of outline what that is in that condition.
Yeah, so hypoplastic left heart, hypo means under or slow, right? And it's basically just a underdevelopment of the left heart. And so I think of this, it's one of our pediatric congenital abnormalities, and it's a heart that just doesn't have as much squeeze as normal. And in this child in particular, kind of like an AFib, when the heart's floppy and not necessarily able to get all of the blood out that it should, clots can form. And he had, as a consequence of his hypoplastic left heart, had developed some clots that had gone to his brain and caused a stroke. And as a result of that stroke, it's not uncommon after a stroke that people develop seizures. And that's what had happened here, is this child had a seizure disorder as a result of his heart abnormality in his previous CVA.
That's unfortunate. And to your knowledge, or did they typically give blood thinners to kids that are that small?
This one was actually on a blood thinner, which is really atypical. And you caught that in your history.
Yeah. When I saw that, I was kind of like, for a 4-year-old, obviously I just had to do something with the hypoplastic large syndrome, but I was like, there was so much other stuff going on. I was like, cool. Once again, just file that one away for later. That we'll deal with it.
Yeah, right. And that especially comes into play if there had been any trauma or anything, because this is essentially the equivalent of a 70-year-old who's on Plavix for AFib. Yeah. This kid essentially has something very similar to that, and any trauma could result in some pretty significant bleeding.
Interesting. So in regards to the present history of what's going on today, was Mom able to provide some insight as to what she had seen prior to your arrival?
Yeah, so Mom said that he had seizure-like activity, and they were prescribed rectal diazepam, and she had never given it before. She had been obviously educated on it at the hospital, and she did exactly what she was supposed to do. The kid was having seizure-like activity. She gave 10 milligrams of rectal diazepam, and she called 911. When we got there, she was still very concerned because he was still unconscious. I'm sure probably some postictal, probably some from having 10 milligrams of rectal diazepam on board. So that's what she was mostly concerned about. But she was actually a very good historian in the process and letting us know exactly what she did, exactly what his conditions were. And so it was nice to have her on scene as a kind of a pro resource on what was going on with him, because obviously we didn't really have much knowledge on it.
That's an important point with these chronically ill children, is their caretakers tend to know absolutely everything and can really be an asset if you include them in the care.
Yeah.
That's a pro move right there.
Yeah.
They're very helpful.
And it's also helpful when they can remain calm. So the more calm that we come in, the presence that we provide to them, it helps them elicit the information a little bit better.
Yeah.
So that was the key too. You guys did a great job on that. So not actively seizing when you initially walked in.
Yeah, he was pretty flaccid.
Biggest concern was probably the airway issues. Did you guys do lung sounds, capno, all that as well?
Yeah, we did lung sounds, and he did have pretty heavy rails in all fields, so that kind of confirmed that he did have aspiration with that vomiting during the seizure. He was having retractions. He was obviously having trouble to breathe. I think he had cyanotic extremities upon arrival too. So initially that made me a little nervous because he was satting low, struggling to breathe, did have a seizure, and we all know with, hypoxia comes bradycardia, which comes, codes in children. And so, like I said, Engine 16 did a good job of getting that blow-by right away, but as soon as we got into the back of 5.5, we just switched to bagging right away. We're like, we're not going to mess around with this. Let's just bag and control the airway ourselves. And luckily at that point, he wasn't having any more emesis in the airway, so we were able to bag efficiently and kind of displace a little of that junk in the lungs to hopefully oxygenate a little bit more.
Yeah, and you hit the nail on the head, just beginning with those good ABCs, the good breathing and the issues that children have as soon as that airway becomes compromised or their breathing becomes compromised. So you did a great job. So at this point, you guys have already loaded the patient, airway's cleared, you're now bagging that patient to have better control over that airway.
So we're bagging, I think our secondary SAT was still 88 for the high. So that was still a little concerning to me that we were bagging this patient on 100% O's. We couldn't get SATs above 90 for nothing. We were still, dropping down to 82 to 88 in that range. Me and the 5.5 medic had kind of talked about maybe doing a OPA, an MPA, but we were kind of worried about putting that in the airway and causing more gagging and more emesis. And so we're like, we'll just we patted on the shoulders and just did that. On a side note to that, it was kind of reassuring when we got to the hospital. The doctor said that kids with this typically tend to SAT only in the high 80s, low 90s on a good day. So that was kind of good to me that, like, okay, we were doing everything we could to keep him par for what the course is for him.
Yeah, you had him optimized.
Yeah.
During your transport, did he seize again?
Yeah, so we were transporting, and he had another, I would just call it tonic activity. He just stiffened up. And this is kind of a weird mistake on probably our fault a little bit, 5.5's fault. We should have got the Brazo out right away and measured him just so we know what color we're working with. When we got to the back of 5.5, they didn't know where their Brazo was at. And so when I had talked to Mom initially, she said their last doctor's appointment, he weighed 30 pounds. And so we just went with 15 pounds for our dosing. So we administered 1.5 milligrams per set IM on the child, and that stopped the seizure. I think when we got to the hospital, he weighed like 16.2 pounds, so we were pretty close to what the dosing was for it. But that was a good learning point for me, is just to Brazo right away, get our color, or bring the Brazo with us so we have our tools available to use for us.
And just to clarify, we said about 16.2 kilos is what he was. You estimate about 15 kilos, 30-ish pounds, what Mom told you. And then the 1.5 of Versed, did it stop the seizure?
It stopped the seizure,
Nice.
Within probably 30 seconds to 45 seconds of giving the Versed, he went back to more of a flaccid state. And all the way to the hospital, he remained in that state. He didn't start seizing again.
It's great.
And no more emesis, obviously.
No more
Everything,
emesis,
airway
And
was controlled.
like I said, the rest of the way to the hospital, all we did was just repeat vitals, bagged him, and kind of just monitored, honestly.
And what was your route for the Versed? What did you opt to do?
We did IM.
IM.
We had got an IV, but we were working on the IV when he started season again, so we just kind of ditched the IV and just got the medication on board, just because he was a 4-year-old with pretty tough veins, and the 5.5 medic did a really good job of getting an IV on him, but it was one of those things where we're like, let's just not wait on this, let's just get it on board.
Yeah. And according to Mom, normal presentation for a 4-year-old otherwise?
I guess that's kind of a hard one to say. I mean, I think he does have some pretty big deficits that he deals with on a daily basis. So I think his normal baseline is pretty low. I don't think he has much of a active life with his normal baseline. So the way he was acting to the way he normally acts was different, yes, but not far off from what he normally does.
Right. Okay. Interesting. And the only reason I bring that up is because you're not, even though your line of treatment was absolutely correct and you guys are doing everything that you need to do, you're maybe not going to get the same response from that kid as a normal 4-year-old to wake up more alert, crying, and the normal response from a 4-year-old. So it's just good to keep in mind. So that was a great job with that. Doc, we hit on it and we checked the glucose and all the things we normally do for the pediatric seizures. What else can we or should we be looking for in peds who are seizing?
Yeah. So I love your approach to this patient. You did an excellent job. You checked a sugar right away. That's something we can fix. Aggressively manage the airway, which we really want to prevent hypoxia in any brain-injured patient or someone with underlying neurological disorder to save all those neurons that we can, and especially in kids watching the respiratory effort. So you look for retractions, look for cyanosis, all those other signs. It's perfect. The only other thing was seizures, and we knew this one did have a seizure disorder, so it was kind of handed to you, and you treated it perfectly. Just one other thing that we see not infrequently is non-accidental trauma, and so I always kind of ask myself in the back of my head, like, could this be a shaken baby or some other trauma? And it sounds like you exposed this child.
As soon as we got on scene, we took off all the clothes. That was one of the first things we did, just to see that breathing, because we could see from the door, obviously, and hear that there was a work going on without even seeing the child.
And this one had some extra risk factors, too, for a potential serious head injury, being on the blood thinner. And then we know, unfortunately, that children who, really anybody who has chronic medical problems and needs another higher level of care, they're at higher risk for abuse. And so having that kind of in the back of your mind to do a extra couple seconds on your physical exam to think about that is always a good idea.
Absolutely. And I think we talk about it regularly. The whole point of these case studies is to give folks the opportunity to hear how other providers, how their peers are treating these unique cases, which this is absolutely one of the most unique cases and conditions that we've ever discussed. What takeaways did you have from this that you would do the same differently? What would you tell other providers who are in your position? Because especially as a driver, upgrading into that officer role at a busy rescue where there's a lot more medical, like high medical acuity often in Station 16's area.
Yeah.
What would you offer some of those new folks that are taking that role?
I think the biggest thing is just, even though I was working with a different crew, when you're working with these other crews in the, farther Northeast Heights who deal with this stuff a lot, just to trust them and to not, because it's easy to, either get sucked into patient care, get sucked into history. And I think the biggest thing for me was just trusting that Engine 16 crew, that they knew what they're doing and they did a great job of it. And then, like I said, the biggest thing for me, which I would take away, is any child like that from now on is just getting the Brazo out right away and measuring with that Brazo first thing, just so we're ahead of the game in case they do start seizing again or anything like that.
Great stuff.
Yeah.
Incredible job on that call. Kudos to you and to Station 16 for their efforts on this. Sounds like kiddo had a good outcome overall. Obviously, it's good to know that that patient is in the district, so now moving forward, that crew and all the crews at that station know how to treat that patient, so that's helpful as well. So outstanding, and I appreciate you sharing it with us. That's all we have for today. If anybody has some interesting cases that they would like to share, enter the SharePoint tab. We have a case study submission page. You can come out and discuss the case, or you can give it to us and we can discuss it on your behalf. Otherwise, reach out to your 7-8. Until next time, we'll see you then. Thanks.